think we're getting there. I think we're not quite there yet. We're not to the point where I can draw a blood sample on an individual and be able to look at a biological signature and tailor their treatment. We're not there yet, but we're starting to put the pieces together that will allow us, hopefully, to be able to do that in the future. Well, I would say we're not using them in clinical practice yet, but I think the things closest to the launching pad, things like NFL, multi-biomarker panels that are getting closer to launch in the clinic, aren't yet tailored to specific individuals, but they'll allow us to look at background MS activity that we're not capturing with the MRI. Part of what was in the talk this morning was coming up with panels that might give us more specificity to allow us to select certain drugs for certain patients. Another concept that we're seeing emerge in MS is that we're having a greater appreciation of how to treat people across the lifespan, how to treat men and women differently, boys and girls differently. So I think we're also moving towards trying to understand where a person is in the lifespan and what that means about their background immunology and how that should tailor our approach, both for efficacy of medication as well as for safety. I absolutely think that this deeper dive into individual level immunology and looking at which compartment, B cells, T cells, innate immune system components, will allow us to get new ideas about targeting therapy. I also think that looking at the background immunology of the host, so to speak, who is carrying that autoimmune disease, whether they are children or older adults, and taking into account immune senescence and hyperactivity of pediatric immune systems, will allow us to better tailor our level of therapy and allow these medications to be used more safely. So we often separate these things. We write papers and we talk about the inflammation of MS and we talk about the neurodegeneration, but they are still linked. And we know that if we let inflammation go unchecked, that patients are going to be at risk of more neurodegeneration down the road. So while we don't have home runs yet in therapies that directly tackle neurodegeneration in MS as well as other neurodegenerative diseases, the better we are at controlling that inflammation up front, for which we do have some medications, the better we're seeing outcomes now. We're seeing the natural history of MS has changed in the last 20 years since developing effective therapies. But we still have more work to do to understand what's driving that chronic neurodegeneration and progressive multiple sclerosis. I suspect and hypothesize that it's related to a low-grade inflammation that goes hand in hand with the immune system and CNS changes with aging that results in a state with chronic low-level inflammation that escapes the regulatory response. So I'm very interested in the role of aging in multiple sclerosis. We started off looking at reproductive aging as a potential factor that could drive a switch to progressive MS. And then I also began investigating the roles of somatic aging. We looked at telomere attrition, and now I'm very curious to look downstream of telomere attrition at the DNA damage response and senescence pathways. And part of what Dr. Amit Baror was talking about this morning was creating this really rich, detailed panel of immune profiling to look at various contributions from components of the immune system in MS. And for me, I was sitting there in the audience, very interested to know how we could adapt that for pediatric patients, which he mentioned, but also older adults, and what are the adaptations we need to do in this platform to capture effects of senescence. I think it's very likely. I treat people who have pediatric MS, meaning that they're having manifestations of disease during childhood, but a lot of the epidemiology points back towards at least adolescence as a key time period for risk. Certainly the risk factor research we've done in pediatric MS points to that, with risk factors as far back as the perinatal period, exposures, possibly chemical exposures in the environment from the air quality for pediatric MS. But if you look at the epidemiology, and where someone's from and their risk of getting MS, it's where they lived in adolescence that dictates their increased risk of multiple sclerosis. Also, we talk about obesity as a risk factor of MS. It's whether you are obese in adolescence that seems to be the strongest risk factor rather than whether you develop obesity in midlife. So a lot of the epidemiology does point towards adolescent exposures as being key for MS risk.
So the tangible benefits of people with MS is an improvement in fitness, if you will. So these are the same things that you would expect for anybody, even if you don't have MS. But for someone with MS, there could also be improvements in balance, cognition, depression, and fatigue. So some symptoms could actually be relieved. And of course, you'll have increased muscle endurance, and strength, and sometimes this can translate to a maintenance of a function as opposed to an improvement of function, depending on where it is that you start any particular exercise program. I think that it is more difficult, in part because people don't necessarily understand the disease process or what they're able to do, and sometimes it's psychological. Because a person, let's take the example of a high-performing athlete who suddenly gets MS, they're deprived of their livelihood, and now if you told this person, oh, you just need to be active, to them being active is high-intensity exercise. So there's a lot of psychological things that have to be overcome first to start kind of getting back into a physical active active lifestyle. And also people, depending on the severity of MS, you may be self-conscious. You may not want to be exercising in a YMCA where perhaps you used to, or even with some of your friends. So there's kind of that personal aspect as well. I think, believe it or not, it's very tangible. It's expense and transportation. Primarily transportation, perceived safety, and by that I mean just kind of a personal space safety, where you know it's okay to have MS and be exercising or working out with this group or even interacting with them. As to a person who's sedentary, how do you get them to make that next step? That one's hard. And that's where you definitely need a behavioral approach. The person needs to be ready to make this first step. And once they make this first step, then you have to make sure that if it's a formal exercise program, that it is structured such that behavioral change is incorporated into that program. For my only independent work, I've done some work looking at recreational ballroom dance for persons with MS. For the ballroom dancers in the group, it would probably be called social dance. But regardless, it's dancing with a partner to formal steps. And I'm promoting that more as a means of physical activity, something to incorporate into your life as opposed to an exercise regime per se. I am also involved with a multi-site exercise trial with Dr. Model, and we're looking at the effects of both a facility-based exercise program compared to more of a tele-exercise approach, which is internet, telephone based. Absolutely. In fact, the big thing I think that has come out in our more formal qualitative analyses of these programs is the social support. And it's meeting new friends. And what one person mentioned was that they prefer it to a formal support group because it's just hanging out with friends who happen to have MS, and you can still discuss things about your disease that come up, but it's not in the context of a formal support group. Sure, that's a tough one, particularly after COVID, particularly if you've just kind of started to take those baby steps into your exercise program. We're trying to get back into it. And I think the thing that I would say, and of course this is getting back into the behavioral or psychological aspects, is it's okay. It's okay to stop. If you have a relapse, it's okay. You can stop. You want to try and not be sedentary, but you can start up again and just take it from where you start, and recognize that it's okay to do that. I think a lot of people think that, okay, once you're up to a certain level, this is it. There's no going back. There's only going forward. And no, not true at all.